So, ladies and gentlemen, welcome to the eighth episode of Endocast, hosted by Ahmed Shauki. Hi, Ahmed.
Hi, Francesca, and of course, my co host, Francesca Chalutti. So, today we are going to raise the bar a little bit and talk about a procedure that is considered as a game changer in managing endodontic pathology.
I bet you're talking about endodontic microsurgery.
Exactly. And I thought it would be nice to have a friend, like always, helping us about that topic.
And I think it's a great idea. So, it is a pleasure to welcome Dr. Ibrahim El Naggar in Endocast. Ibrahim is a very skilled clinician and is a silver member of Style Italiano Endodontics. So, hi, Ibra.
Hi, Francesca.
So, Ibrahim, microsurgery can help us solving many problems when the orthograde treatment or retreatment therapy fails, or it is not the best option to pick. I would like you to help us to understand the decision-making process that brings you to decide that you are going to do a microsurgery on that particular case.
The first indication for endodontic microsurgery is for sure the development and or the persistence of a lesion and the presence of in the presence of good endodontic treatment. Like sometimes you are having a good endo and you don't have any cause of the failure. Like you know that the process of cleaning is very good and the process of obturation, the shaping, and the normal procedures of the root canal treatment, they are all fine. And sometimes you are surprised by having a lesion, even sometimes in your own treatments. So that's why we can consider that the surgery may be the best option to treat these situations.
Of course, before retreating, we should ask ourselves whether we are able to improve the existing treatment or not. And if the answer is no, there is no point in choosing the retreatment approach. So you said that uh, conventional endo can have limits. Could you tell us more in detail what you are referring to?
First of all, we know that we are having an enemy, which is called the isthmus, because sometimes you treat a case, and this happened to me, to be honest, many times in my treatment, that I treated cases, and I am surprised that the patient is still feeling some sort of pain and a little bit discomfort. And of course, I don't want to say perfect treatment, but at least I need to achieve the goal of root canal treatment that the patient is feeling comfortable after the treatment. And these patients come and asks to me why I still feel the pain. And I have seen that everything in the normal radiograph is fine, probing is fine, and as well on the CBCT all is good. But sometimes when we go to check a little bit deep, we can find we are having another extra anatomy, or let's say the isthmus, and this sometimes couldn't be cleaned by the normal way or the procedure that we are doing daily, but you have to intervene surgically to clean this area from bulb tissue, bacteria, and so on. And sometimes as well, you can see that from the lesion being too long on the root surface for too long time, this lesion may undergo some sort that we call calcification, that the lesion from the outside becomes more calcified. And for this reason, whatever you did in the treatment or retreatment, you are not going to remove this kind of calcification or attachment from the lesion on the root surface. That's why you have to intervene and you have to do like what we say, the mechanical debridement for the root surface, that we have to go and intervene. And this is a process we all know, which is the post-treatment disease, a persistent apical periodontitis that sometimes it's rarely to happen, but when it happens, you know that you have to go and intervene surgically with this patient. Another kind of indication for the surgery that you are going to have a persistent lesion. Like there was one of my patients. He was a child and he was like 13 years old, and he came to me after a referral from a surgeon from the hospital, and he told me, like, I went for the hospital, I did the surgery, and the surgeons went to remove the cyst, and it came back after like 6 to 7 months. And when I take the full history, I saw that this guy got an old trauma in his frontal tooth, and after that, he went, of course, for a pulp necrosis and so on. We know the consequences, and a discoloration, blah blah blah. Then the patient went to the hospital. Surprisingly, they just removed the cyst, and this, of course, cannot happen because we all know that we have to remove the source of the infection from the beginning. So one of the most indication of the surgery that we can see, like more than 70% of the cases, is the removal of the cyst. Sometimes we have a cyst from an endodontic origin, and this is called the pseudocyst. And sometimes we have another type of cyst, which is a true cyst. Sometimes it came from the endodontic origin, but it have no communication with the endodontic cavity. So whatever you did in the endo, you have to go and intervene another more appointments in the surgery. After that, sometimes you can face a treatment which is good, and you did the full retreatment, and after the retreatment as well, you didn't succeed for the healing of the case. Okay, so that's why you may intervene and go further for this patient with the microsurgery. Okay, because in my clinical practice, I faced this kind of situation like 3 to 4 times that I did for the patients a good endo, and I'm sure we did a good job, and I did the retreatment with no significant difference in the patient discomfort. The discomfort is still the same. So once I went and I intervened surgically, all went fine. Of course, not on the day of the appointment, but like 2 to 3 weeks later when we go in the process of the healing.
Okay, so that's for sure the absolute indication for endodontic microsurgery, because we cannot just remove the extraradicular infection or extraradicular biofilm, as you said, that can happen in a calcified form from inside the root canal. But I think there is more from what we see from your cases. Other situations in which you prefer microsurgery, not, other than these indications.
Yes, of course. Once I put the surgery as an option for a treatment in my cases, let's say sometimes the problem is not related to good or bad endo. The problem is related to that this is the only situation, or this is the only solution. Like sometimes I see the caterpillar floating in the bone, and there is no way to get this by retreatment. You have to intervene and you have to open the flap. As well, sometimes we are having a prosthetic treatment in the tooth, and as well, we are having a fiber post that is having all the length of the of the tooth. So that's why I have to intervene surgically. I cannot go and drill all the way the fiber post and try to remove the cadaverca, then replace the post. I think this is a little bit destructive. And on the other hand, we can see sometimes cases that you are having a huge lateral root perforation that it's like impossible to go inside again and to regain the original pathway. Like one of the cases, I was having a huge lateral root perforation, and when I tried to get the original pathway, the referring dentist was blocking a file and an irrigation needle inside the main pathway. So of course there is no way to get inside, and luckily this case was having like 23 millimeter long root, so it was easy for me to intervene surgically, and I think as well this was the only solution. And you can see this as well in cases that you are having separated instrument, which is coming in the most apical part of the root. Sometimes you can fix it with extreme perforations in the apical part, that you cannot do anything or seal this huge defect, but I have to get in and cut the root and try to like visualize the area and to make sure that I place the MTA or the filling or the repair material in a good form. When I started to apply the surgery in my treatment, it opened my mind for different modalities of the treatment. Like sometimes this patient, or one of the patients, let's say, came and she was having a problem like in only the mesiobacral root, and unluckily, I wasn't able to seal the perforation because she got a huge perforation and we got a large amount of granulation tissue inside as well. We lost the buccal cortical plate due to the presence of the lesion. So just knowing some of the surgical procedure, we went for removal of this defective root only, and with some prosthetic solution, we could deliver for the patient a good crown to overcome the absence of the medial root. And like we are having, it's in the start having like 2 or more than 2 years full up till now, and everything is fine. But at least if this treatment will not, if it's not going to be a lifetime treatment, at least we regained the bone back for the patient. So in further way we can place for this patient an implant. That's what we call an endodontically guided bone regeneration, because sometimes it's impossible to deliver the patient the final implant without having the bone. And in a case we are having a complete loss for the buccal cortical plate, which is of course mandatory for the implant.
I totally agree with that. And this is strategical thinking because even if endo is going to fail over time, then you have another options for your patient. So it's smart
Of
thinking.
course.
But
Exactly.
I think there is one more case in which endodontic microsurgery is the most conservative option.
Of course, there is another situations like the cases that you are having a full fiber post in the canal. I remember one of them, or one of my patients was coming like the full central was obturated with a fiber post. Like I have only the apical to 2 millimeters that were having just a smell of gataperca, not a gataperca even. So the only solution, I remember this case, I digged inside the fiber post itself to put the MTA, and one of the patient as well was coming like 200 kilometers, and he was referred from a patient, from another dentist, for me to remove the file which was in the apical part. I told him this is impossible for me to remove the file, and we are going to be very destructive. You have a crown, you have a getaperca, you have everything perfect. We are just going to open a small opening in your mouth or in your gum, and then after we are going to remove this small tiny file, and we are going to place the final plug in the root, and we are done. So when you know the surgery, you are having an extra. I call it like an extra card in retreatment, because you are not only having a primary treatment and a retreatment.
Does it ever happen to you to follow the requirement of a patient that asks for surgery because he doesn't want to remove the crown, maybe because it's a recent crown, etc.?
We don't have this like the way of thinking here, but of course the patient having a crown, he wants to keep the crown. And by the way, my first surgery was indicated for surgery because the patient were having a bridge, and one of the pontics or the abutments, sorry, were having an apical separated instrument, which was an edge file. So I told him like, I have two options. I have to remove this bridge. He told me, no, 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 I will not remove this bridge. So I offered them the other solution. We are going to open just a flap, and we will remove the file, and everything will be fine. So this was my first surgery actually.
Yeah, I totally agree that surgery is considered one of the conservative approaches in those situations that you have mentioned. But I want to ask you about the patient that you told him that we will open a small opening. What did he feel when he saw the microscope with a big opening on the screen?
No,
Did he panic?
no, I'm very selective for what I'm showing for my patient. I only show my patient when I'm going to do a very nice and a beautiful cosmetic restorations because I do resto as well.
Uh-huh.
So I'm going to put him a veneer. I'm going to show him a restoration with a tint and translucency, mamelons, blah blah blah. Doctor, you are very very artistic doctor. And when it comes to the surgery, we just rotate the screen so it comes on for assistance and the next step that I need like the ultrasonic tip, the mirror, and blah blah blah. I prefer to give them the final record for the surgery because sometimes we go intention inside the surgery like please open your mouth, don't close, I will retract a little bit more, doctor, I'm got tired, blah blah blah. So when he sees this, he knows exactly what we were doing, like it was a
Exactly.
hard.
Yeah. So, one more thing about the microsurgeries. We know that when we do retreatments, non-surgical retreatments, and we have a failure and we decide just to do another retreatment, the success rate, according to literature as well, is dropping way down when you have another retreatment. What about surgeries? Do you do resurgeries, and how you find the outcome of resurgeries?
For the resurgery that I did, of course, the previous treatment was only done through a gutta and you go to cut the apical part of the root, and that's it. We call this a surgery,
Mm-hmm.
but not correct because if we called it like a surgery or a microsurgery, we have many subcategories like you're having the anesthesia, the diagnosis, the flap, the osteotomy, the reflection, and blah 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 till we reach the suturing and the follow-up. Because I have learned recently that the timing that you remove the suture is very important, the way, the type of the suture, and so on. But for the surgery that we see, it's like we see in the hospitals, we are having a bisectomy. Like I have a cystic lesion, I'm going to remove the apical part and part of the lesion, and everything went fine. This patient told me I got the surgery 7 years back, and after 7 years, what happened? A lesion became more and more messy, and we got an ongoing resorption sometimes on the root. Another research is that I do that the one that was made on amalgam, we see like tattooing on the gum of the patient, like he have a black gum from inside and sometimes fenestration and this stuff. So that's why I'm trying to spread the idea that the microsurgery is not just cutting the apical part and closing the flap. It's a lot of procedures. At least if you are going to do this or you are going to do it this way, please remove the gutta put MTA and then open and cut. There is no problem. But sometimes in molars you may get some failure because you cut and you expose the isthmus. So, but like we say, half of the problem, not like the full problem. Okay. So if you are to do the surgery by cutting just the apical part of the root, at least open the access cavity and remove the cataperca and put for this patient some MTA. Even if it went out of the root, you are going to clean all of this from the surgical access.
Yeah, of course,
Mhm.
seal is paramount importance. Otherwise, you're not doing endodontic microsurgery. You're just doing
Of course.
surgery. And
Roll abs.
Up to now, we have seen very nice cases and very nice indications, but is there any case in which you say, no, I'm not doing microsurgery in this case because it's contraindicated?
Yeah, a lot of cases, especially when we are going to have. I want to mention that the first cause for the rejection or contraindication of the microsurgery came to a medical and anatomical contraindication, and sometimes it went for the patient himself. Like this patient is asking too many questions, like how doctor I'm going to feel, will we finish quickly, blah blah blah. This kind of patient that who are not accepting the treatment, I cannot offer them the treatment. And the patient of course are having a problem and having a diabetic problem, hypertensive, and taking some sort of medications. These are as well contraindicated for the microsurgery. But sometimes I have um, a case that we are close to the sinus. I don't want to call them like absolute contraindication. It's called a relative contraindication because you may cut. It depends on the cut. It depends on the flap and the way you are going to remove the root. Because you may remove the root aggressively, so you perforate the Schneiderian membrane or the sinus, and sometimes you are going to do the job very very slowly, and you are going to do it correct in the correct way, so you are keeping the sinus intact and everything fine. So that's why I call it like a relative contraindication. It depends on the skill of the clinician and on the situation and on the tool that you have. And other part is an absolute contraindication, like you are having the whole roots inside the sinus. This is impossible to do because you are going to cut the sinus, no way, 100%. And when we talk about the sinus, it's of course on the upper molars. When it comes to the lower, it depends on the, the nerve and the thickness of the buccal cortical plate. Sometimes we're having like 5 to 6 millimeters in the first molar. It increases to 8 millimeters in the second molar, and it goes up to 11 millimeters, between 9 to 11 millimeters in the third molar. So I'm not going to remove part of the tooth and remove a whole bunch of bone like this from the patient. It's impossible because when you have a very huge amount of the buccal bone, you're having less amount of lingual bone. We see this too much in the lower second molar because that's why when I have a problem in the lower second molar, the only treatment I think about, and I want to do the surgery, of course, the only treatment I think about is reimplantation. That's why the reimplantation is part of the surgery, because if the surgery is contraindicated, we have to go for the reimplantation. And this, of course, depends on the skill that you have in the traumatic extraction, the way you remove the tooth, the armamentarium, because sometimes you remove this with piezo, and sometimes you remove it with pesotome or periotome. Sorry, of course, the pesotome may be way faster and better. So it mainly depends on the tool that you have, the time, how fast you are, because cannot stay outside the mouse for more than 8 to 10 minutes. We are going back to talk about the contraindication, which is anatomical, but in the second molar in the upper, in the maxillary second molar, because we are having an anatomical contraindication, which is a greater palatine artery. If you are having a problem in the palatal root of the upper second molar, it may be a problem that you open the flap in this area because it's branching or the opening of the greater palatine artery, and if it went for bleeding, it will be messy because this is the main branching for the maxillary palatal roots and the palatal mucosa of the teeth as well. Then we can go back for the premolars when we are having the nerve specifically, because in the premolars we don't have the problem of cortical plate, we are only having the problem of the mental foramen. But it as well could be both of the contraindication. It may be a relative contraindication, it may be an absolute contraindication. Because if it's too close, and it's like in the tooth is including the nerve, it may be very hard to bypass the nerve. But sometimes you can see that the nerve is below, like 1 to 2 millimeters of the premolar. In these situations, it's not as well a problem because it depends on the location of the osteotomy. You are going to make your osteotomy more coronal, and by this way, you are avoiding the nerve. And of course, the rule of magnification cannot be missed in this case. The last thing I can consider, which is the most important thing, because it's the first step in the microsurgery, the gum, the periodontal condition. If the gum is full of inflammation, teeth are full of calculus, you're having abscess, you're having granuloma and fenestrations and so on, it's a little bit contraindicated because you have to readjust the periodontal condition, and you have to go back for the surgery. That's why in my surgeries I advise the patient, or I don't advise, we actually force the patient to go for a prophylactic treatment 1 day before the surgery. Even if he's not near to my office, he can do it in any near office to his home.
I totally agree with you, and we can see from all those indications and contraindications that the pre-surgical planning and evaluation for the patient is very important. We do not just go and perform the procedure without perfect planning before doing that surgeries. So thank you for explaining the indications and contraindication of apical microsurgery, but I think that we need more episodes, in matter of fact, to clarify how to prepare for the surgery which I was talking about, and what are the steps and the new techniques, for example, in endodontic microsurgery. What do you think, Francesca?
Yes, absolutely. I was about to say the very same thing because there's a lot to say on this topic, and I think we should take more time to just go inside every aspect of endodontic microsurgery. So, thank you, Ibrahim, for joining us. It was amazing. I hope you're going to join us again if you have time. So, guys, thank you very much for watching us, and stay tuned for the next episode of Endocast. Bye.
Bye bye.
Bye.